Good day. I'm Dr. Emanuela Palmerini. I'm a medical oncology. I work in Bologna, Italy, at Istituto Ortopedico Rizzoli. This institute has a long-standing tradition of orthopedic surgery, so I had a large exposure to patients with the Tenosynovial giant cell tumor, and I'm happy to present on how optimize the treatment of this patient today. So this tumor is a locally aggressive benign tumor arising from the synovium and the bursa and the tendon sheath, as you can see here in a macroscopic section and a MRI and on the knee of this patient. This disease has been treated mainly by orthopedic surgeons for a while, and the naming has been confounding. The past former name was pigmented dilonodal synovitis, but it is not. It's a tumor. It's a since the new classification in 2012 and now from the most recent 2020 is called Tenosynovial giant cell tumor, and it is the sole name we should be using. There are two entities under this name: localized, as you can see in the upper MRI, and diffuse, where, as you can see, all the synovio is interested from the tumor, and also there are the white spot, large edema associated with. And the difference in between these two entities is not histological, but it's mainly morphological and linked to the size of the disease. So nodular is usually 2 centimeter, while diffuse is usually more than 5 centimeter. The localized may be cured by surgery and it was circumscribed, while the diffuse is very aggressive and usually eroding also the bone. And the incidence, it's likely different, 4.1 per million person a year in case of the diffuse, while the localized is more frequent, 10 patients per million person a year. So both quite rare, but the diffuse might be defined very rare. And this body simplify the location most affected by the two entities. So knees might be affected by both localized and diffuse, and while the hip is usually diffuse, and the localized is most often in the small joint of the ends. Roughly, we will have about 1,500 patients with diffuse tenosynovial giant cell tumor. So not a lot of patients to address a lot of questions on the treatment. The pathology include 4 main cellular type: giant cell, which you can see in this slide, have also till 100 nuclei, and then macrophages, which are foamy macrophages, the white TC shell, mononuclear cell, those very monotonous with the blue dot, and siderophage, the reddish one on the left. And this is the presentation, and these cells are represented differently in the localized and the diffuse type, and they can be appreciated in micro slide, but also in the macro section of the tumor. So the diagnosis is quite easy, both from a pathological point of view for the presence of hemosiderin deposit, but also from the MRI. And as we said, these diseases should be classified as a tumor. In fact, in 1994, this paper came out, Dal Chin, underscoring that all the two lesions have a pathogenetic fusion SF1 and COL6A3, which causes overexpression of this transcript, which causes the growth of the tumor. But the peculiarity of the disease is this loop in between neoplastic cell, the purple one, and the inflammatory cells. So the symptoms are driven by both components, the tumor and the inflammatory cells, that paracrine loop, which causes the activation and the increase of the inflammatory cell infiltration. The diagnosis is quite easy, as I say, pathologically, but also on diagnostic standards. It can be recognized by X-ray, on a CT, which can be useful to appreciate a bony destruction, and on MRI. MRI is the golden standard approach. We can use MRI also with no contrast median, because the lesion is this big lump on the popliteal fossa of this knee. Here you can see a 10 centimeter lesion, and it's very dark on T1, so easily to recognize. And the shape is finger-like in many spots within the knee. And the severity of the MRI, it's very important, and has been addressed in the study by the Dutch group. And as you can see, the relapse free is maybe very difficult according to the severity of the appearance on the MRI. We performed a study together with colleagues in New York to study the likelihood of this disease to recur, and along with size or histotype, diffuse, of course, relapse much more frequently than diffuse, we found out that the people that experience a relapse for the first time have a very, very likelihood of a second relapse. So they should be treated in a referral center from the beginning in order to try to reduce the likelihood of relapse, which really affect the prognosis of our patients. And we performed a larger retrospective experience. This is a platform which included more than 1,200 patients from 31 tertiary centers, and the primary objective was to gain insight on this rare disease. And as you can see, there were two publications from this group that underscore the difference in recurrence rate from the localized type, which has a relapse rate of about 12%, while patients with diffuse type have a very high relapse rate risk, 44%. So almost 1 out of 2 patients with a diffuse mild relapse. These are the curves again, as you can see in the yellow line, patients that have recurrence would very frequently relapse. The relapse-free survivals is only about 35%. So most of the patient, more than 60% of the patient will relapse. Also, this study addressed the role of type of surgery. In patients with a new diagnosis, the arthroscopic approach, the yellow line, was associated with worst outcome. So the bottom message is when you have a new diagnosis of tenosynovial giant cell tumor on the knee, it's better to approach it with an open access. The quality of life is definitely deteriorated in this patient, and in this population, we were able to also to assess prospectively the quality of life, to see the impact of this disease on the patient outcome. So here you can see that over time, patients that have worse quality of life and increase pain, usually change their treatment. So it is very important to collect all the information on patient pain and patient reported outcomes in order to address the treatment question in this population. And surgery was the standard, but now there are several other options, and we are going to discuss about those options today. So the first drug that was used in these patients was used accidentally in 2008 by the French group. This imatinib is a CS1R inhibitor, and this case report by Jean-Yves Lehy showed a complete response. As you can see here, the knee, this lesion was rapidly decrease under treatment. So as after this first experience, there were several studies with CS1R inhibitor. This is a retrospective study by Cassier, another French investigator, and 22 patients were treated. And as you can see, for the tumor growth, this is the bars on the right are the reduction. So there is the complete response, and then most of the patient having more than 30% reduction. So the partial response in this study was about 14 partial responses and 3% complete responses. So good results. And then more drug followed. The most famous is PLX3397, pexidartinib. It is famous because the 2 of August 2019, so 5 years ago already, was approved by the FDA for the treatment of this disease. This complex and nice figure is called kinome, and shows the red dot how specifically this drug is able to target the CS1R inhibitor. And as you can see, PLX is very specific, more specific the imatinib. And this nicely will translate in activity of the drug. One of the peculiarity of the disease is the growth pattern. As you can see, is very finger-like, difficult to measure growth because it's all around the bony, which usually cannot be measured. So racist is just one diameter, but tumor volume score was implemented in order to better represent the activity of the new drugs. And this is one example of a tumor response by tumor volume score, as you can see at 4 months. If you consider the longest diameter, which is racist, this might be considered a stable disease, while the reduction is really clear, and the symptomatic also activity is important. So the study that brought to the registration of pexidartinib was a randomized study matched to placebo, and all the red point are the assessment. So it is the first study that underscored the importance in this kind of benign, locally aggressive disease of the patient-reported outcomes collected current treatment, and of course MRI, but also range of motion, so the limitation caused by the disease. This study included all patients with advanced symptomatic tenosynovial giant cell tumor, and when surgery was associated with potential worsening of the function. So very advanced cases. This is the table showing the 60 patient undergoing pexidartinib and 60 placebo. No difference in age, and about 90% in both arms received no prior systemic treatment. Interestingly enough, about 50% of the patient already had surgery, and this is the response. So this waterfall plot, which is a kind of graphs that oncologists like to see, it's really nice because the red line is the 30% tumor size reduction. This is by RACIST, so this is very good because it shows that 15% of the patient had complete response and 25 partial response. So overall, almost 40% had racist response, and zero actually in the placebo arm. So this drug was really active in this population, and as discussed, tumor volume score was, of course, able to better depict the nice response of this population with 56% of patients responding. And this is one case that we showed to several congresses just to show you the impact of the drug on the disease. This is a patient from the Milan team that had the disease all around the fingers, and sometimes the disease might be very aggressive, as I say, also, but is still benign, no metastasis. And this is the changes over a 2-year period. The problem of pexidartinib was hepatotoxicity. Due to this program, the drug was denied approval in Europe because the therapeutic window in a benign tumor should be very carefully considered. So a few patients had increase of transaminase, but also increase of bilirubin, and this was considered not too toxic for a benign disease. So in Europe it was not approved, while in US it was approved, as I said, in August 2019 under this RAMS program. RAMS is a program that require prescriber to be certified in order to be enrolling patients. So the safety of the patient is guaranteed. There are other compounds on the same class coming along. Vinceltinib, DCC 3014, is another oral kinase inhibitor, which is very potent on this receptor. And a couple of years ago, the results were presented at ESMO, and as you can see, the waterfall plot is very, very similar. There are two cohorts that use different doses, but nowadays the drug is given orally twice a week, 30 milligram per day. And the toxicity associated with this drug is mainly on blood pressure changes, nausea, but less problem related to hyperbilirubinemia. As increase, though, was reported in about 17% of the patient. And this is the randomized study that was presented this year at ASCO, and the concomitant publication on Lancet showing that vinceltinib was able to reduce the disease in most of the patient. The overall objective response this time was 40%, so very similar to pexidartinib, and also the duration of response was quite good. So, as I said, the most important responses in tenosynovial giant cell tumor are patient-reported outcomes, and as you can see, the drug significantly improved pain, function, and stiffness. Based on this, it will be also submitted to FDA and EMA. The side effects, as I said, are confirmed, mainly hypertension, periorbital edema, and fatigue, but increase of AST, but not hyperbilirubinemia so far. So the last drug studied for TGCT, it's emactuzumab. Emactuzumab is a very different drug because it's an infusional approach, and also it is administered on a specific period of time, so only 10 weeks, not continuously as the other oral drugs talk about. These are the results presented in European Journal of Cancer 4 years ago. Only 60 patients treated, and 92% have disease in the lower limbs, and 60% had prior surgery. And this is the activity. Again, this target CZF1 receptor seems to work very well, both from morphology. MRI showed tumor volume reduction in most of the patient, but also from a functional point of view, this is a metabolic change because TGCT, it's very glucose avid, and this metabolic response is associated with symptomatic response. Also, on the bottom line, you can say the study day and the duration of response, it's quite good for most of the patient, also meaning half treatment. The tolerability is good, with most 60% of the patient experiencing asthenia or pro-itching, 70%, but no lot of liver toxicity. And in this table, comparing the four drugs I presented today, as you can see, pexidartinib and vimseltinib are more associated with the liver enzyme, pexidartinib bilirubin, and also hair color changes. I didn't mention that because it's in oncology it often happens, and it's totally transient, but it is not reported so far with emactuzumab. To conclude, there are two types of TGCT patient, nodular and diffuse. And in the past, surgery was the main approach, but also active surveillance should be considered. And this recent study showed that almost 70% of the patient did not needed treatment. So this is important to consider that as well. And I tried to simplify the treatment pathway of this disease with this approach. So symptomatic disease should undergo treatment, while in lack of symptom, active surveillance is the best approach. When we should treat, we should consider the morbidity of the surgery. So if the surgery is not very associated with morbidity, surgery should be considered. And in case a surgery is likely to remove all tumors, open surgery should be used. While in case with high morbidity related to surgery or surgery unlikely to remove all tumor, neoadjuvant upfront pexidartinib or other CFS1 inhibitors recently studied should be considered. And in case of partial response, this approach might be considered neoadjuvant, so surgery might be used successfully after that, or in case of complete response, drug holidays might be used, and then the drug always works at rechallenge. So this is a new area for the treatment of this disease, and all the therapeutic armamentarium have changed, and in the future, we will see the role of vimseltinib, which is not approved, and also, of course, emactuzumab. For now, we should keep collecting patient-reported outcomes and listening to our patients, and to get insight in this complex disease. All global expert, recently published best clinical management that might guide the treatment of these rare entities with all these new avenue of opportunities coming along. Really think that we should consider the differences in between patient and localization and born of the disease on the symptoms. Of course, early referral is very important, and none of these consideration might be performed without the strong collaboration with our peers, so oncologists, surgery, radiologists, and pathologists, and all the multidisciplinary team component, which are very important for TGC team. And I thank you for your attention.